is Maria Lambadaris. I'm one of the C2 cardiology residents, and I chose to present on cardiac amyloid today for the echo rounds. The objectives of today's talk are, number one, understanding the pathophysiology of cardiac amyloid and the common clinical manifestations, to identify red flags on echo that should raise suspicion for diagnosing cardiac amyloid, and then how to appropriately use echographic techniques when we assess a patient for cardiac amyloid, for example, measuring structures appropriately using Doppler and strain analysis. This is today's outline. So we'll start off with some pathophysiology and clinical presentations. I'll then go into a bit of a patient case we had a couple of weeks ago. And then we'll delve right into the red flags and how to really assess the different cardiac structures. We'll go through some examples of LV strain, and then I'll touch on the guideline recommendations for following up these patients with non-invasive imaging. So to start off, what is cardiac amyloid? It's essentially a group of heterogeneous disorders in which we have these misfolded proteins that deposit into the myocardium, other cardiac structures, and elsewhere in the body, such as our neurological system as well. From a cardiac perspective, they cause an infiltrative cardiomyopathy that manifests as heart failure symptoms. And this can be both left-sided and right-sided heart failure. And usually we think about two main precursor proteins that lead to cardiac involvement. So number one is our immunoglobulin or AL amyloid light chains. So this is the misfolded clonal immunoglobulin light chains that we often see in plasma cell disorders or B cell disorders. Then we also have the liver-derived transport protein transthyretin, TTR, and this is essentially pre-albumin and a tetrameric protein that is made by the liver, and it's named for its role in transporting thyroxine and retinol binding proteins. Sometimes when we get amyloid from TTR, it can be a result of a gene mutation, and usually we refer to this as hereditary ATTR amyloidosis. And then another variant we can think about are those that alter the actual protein stability. And this is something we see in older patients who don't necessarily have a mutation. And we refer to this as wild type ATTR. So both the AL and ATTR amyloid have similar phenotypes. They both cause increased left ventricular wall thickness, and they often disguise as different disorders, such as heart failure, atrial arrhythmias, or aortic stenosis. And because of this reason, they're often undiagnosed, and we don't necessarily know the true incidence or prevalence of ATTR in the population. There have been some autopsy studies that looked at the myocardium and found the deposits of ATTR in up to 25% of individuals that are older than 80 years old. And then other non-invasive methods have also identified ATTR in 13% of patients with HFpEF, heart failure with preserved ejection fraction, 16% of those patients that had aortic stenosis and underwent a TAVI procedure, and 5% of patients that had hypertrophic cardiomyopathy. So there's really more than 30 different identified precursor proteins, but really only a handful of these actually affect the heart. And when we do find patients with AL amyloid who have cardiac involvement, this often confers a worse prognosis for that patient. With respect to ATTR, cardiomyopathy is more heterogeneous and really depends on what type of mutation these patients have. So how do these patients present? So in AL and ATTR, heart failure is by far the most common type of presentation when the heart is involved. But then other things we should think about are syncope and orthostatic lightheadedness. For example, you have a patient who's been hypertensive for years on multiple agents, and all of a sudden you're having to cut back on their therapies, especially beta blockers or ACE inhibitors. This should raise a bit of a red flag of, is there something else going on here? Oftentimes we see conduction system disease, mostly atrial fibrillation or atrial flutter, but ventricular arrhythmias can also occur. Low flow, low gradient AS has also been reported in old patients with ATTR. And then finally, angina is another manifestation. And this basically happens because the amyloid deposits around our coronary microvasculature, or rarely can cause a myocardial infarction in the absence of any intraluminal disease in the epicardial coronary arteries. So when looking at the two types, ATTR is often a slow progressive disorder that we see commonly in older men, and they often have greater ventricular wall thickness and a lower ejection fraction. AL amyloid is a rapid progressive course in young people and doesn't have as much of a male predominance. So I'm going to move on to a patient case. This was a gentleman who was a trauma patient. And they sent just a general echo to do workup, see if there's a cause for syncope, et cetera. There wasn't really any history of amyloid diagnosis for him. And this is his ECG here. Does anyone want to just highlight some abnormalities on the ECG that they see?
Atrial fade.
Yeah, great.
On the H block.
Not typical ones of
There's some low voltages.
Yeah,
laterally,
yeah.
And maybe a little bit anteriorly as well.
Yeah, exactly. So low voltage, atrial fib, all kind of suspicious here. This is his echo. So these are the parasternal views here. Anything that's standing out to you guys from the first shots on this echo? The walls, I think. Yeah.
I was like that speckled pattern on the myocardium.
Yeah. So thick walls, speckling. There's some left atrial dilatation here. The valve, like the mitral valve here, also looks a bit thickened too. And then when we go to measure the walls, indeed, they are quite large here. And this is the apical four-chamber. Anyone want to add any other findings we see here? Yeah. Exactly. So again, we see the biventricular wall thickness. We see the biatrial enlargement. There's probably some interatrial thickening here. We have pericardial effusion. So all quite suspicious. When we did the Dopplers for the mitral valve inflow, we see there's quite an accentuated E wave compared to the A wave, greater than an A ratio greater than 1.5. And then our tissue Dopplers here also quite low. So on the lateral side, it's around 5 to 6. And on the, I don't know why it keeps advancing like that. And on the septal side, it's around 3. So quite low velocities. And I just wanted to show the other views from the apical window, or 5-chamber, 3-chamber, and 2-chamber. And again, we see the same sort of constellation of findings that we saw in our other views. So these are some of the red flags that we should all be thinking about when we see a person with increased LV wall thickness. Are there any other signs that could point us to the diagnosis? And echo is often the first test we get that should raise the suspicion for cardiac amyloid. So we spoke about our biventricular wall thickening, biatrial enlargement, increased LV wall thickness with low voltage criteria on associated ECG, diastolic dysfunction and elevated left ventricular filling pressures, reduced mitral annular tissue Doppler velocities, reduced GLS, global longitudinal strain with an apical sparing pattern, low flow, low gradient aortic stenosis, pericardial effusion, increased atrial septal thickness, diffuse valve thickening, and a preserved ejection fraction with a low stroke volume. And this is one of the figures from the American Society of Echocardiography that describes a practical approach to imaging patients with cardiac amyloid. And another classic case we see are thickened left ventricular wall, left atrial dilatation, pericardial effusion all around. We have some mitral valve thickening here. So when we see these, how are we going to properly assess them on echo? So we'll start off with the measurements. First off, the interventricular septal measurement. And this can sometimes be challenging because the RV can also be quite thickened and can impact our proper measurement of the LV wall thickness. So in red, the arrow here is kind of the wrong way to measure the IVS because you're taking into account your RV wall and your LV here. And you want to sort of aim for the yellow arrow here to measure your IVS. And oftentimes the American Society of Echo recommends that we measure in the short axis as well, just to get as accurate a measurement as possible for LV wall thickness. When we look at our right ventricular wall measurements, this is best evaluated in the subcostal window, and we want to zoom in to that area here. We can use M mode to do the measurement at end diastole, and you want to place the cursor just a centimeter below the tricuspid annulus at the level of the leaflet tips when the valve is fully open. And then you can measure the wall thickness in M mode or here in the orange arrow in the subcostal window. Look, moving on to our left atrial measurements, oftentimes when we're doing our apical 4 and apical 2 chamber, we're really trying to optimize that left ventricle, but it's important that we also think about optimizing our left atrium, and it might not be in the exact same axis that we see that beautiful LV image. So this is an example from ASC again, showing that if you were to measure your left atrium where you also measure your left ventricle, you can actually underestimate that left atrial volume index shown on the left side. And on the right side, they show how changing axis and optimizing that left atrial picture really gives you the right measurement for your left atrial volume index and can be another sign of cardiac amyloid as we discuss. So now I'm going to move on to Doppler techniques. So this is also very important because when the amyloid fibrils infiltrate our myocardium, this results in abnormal relaxation of our LV and progressive diastolic dysfunction. And this degree of diastolic dysfunction is reflective of the disease course. So there's more severe diastolic dysfunction as the disease progresses. So panel A is our pulsed wave Doppler of the mitral inflow. Usually patients start getting grade 1 diastolic dysfunction very early in the disease course, but when we see them, they're usually more progressed and they manifest with the grade 2 or grade 3 diastolic dysfunction. And the thing we see on mitral valve inflow classically is a high E wave and the E to A ratio of greater than 1.5 to 2 with a short deceleration time. When looking at the tissue Doppler of the mitral annulus, we see that the velocities are often very low, about 5 centimeters per second, which also reflects abnormal relaxation of the myocardium. Here we can see in panels C and D the low velocity tracings. When we look at the pulmonary vein velocities, these reflect our LV diastolic dysfunction and atriopathy, and commonly we see a decrease in the pulmonary S systolic wave because the left atrial pressures are higher, with a concurrent increase in our diastolic D wave as the disease progresses. And then in the atrial wave, we see pulmonary vein atrial reversal velocities that are larger, and this is often a reflection of increased LV and diastolic pressure. So it's imperative that we do the pulse wave Doppler for mitral valve inflow to evaluate diastolic dysfunction. And how do we do this properly? Well, ASC recommends that we have the appropriate sample volume size, 1 to 3 millimeters, because this can affect the appearance of our waveform. And it's crucial that we position our sample volume correctly just at the leaflet tips, because if we put it too far into the left ventricle, we can underestimate the E and A velocities and be misguided. Tissue Doppler is also important. Here they recommend that we use a small sample size, 5 to 10 millimeters, so slightly bigger compared to the mitral valve inflow. Again, we want to position our cursor right on the ventricular side of the annulus in the basal myocardium. And align it appropriately with the axis of movement in the annular plane. Ideally, you want to get these measurements at the end expiration. So now I'm going to move on to
Just a couple of other points there.
Yeah.
Just go back one. I think the other trick that we have to remember here is this is a Doppler assessment. So you need to put your color box on and look at the direction of flow, because if you just take your non-optimized data before chamber view, as you know, flow normally he goes out to the lateral wall, comes around the apex, and then gets ejected out. So if we don't optimize for that, you're going to get about 25 degrees off the Doppler, which will mean you're going to underestimate the velocities by about 25% there. And so unfortunately, you do need to then, as you know, go off the standard axis. And then for the same thing again with tissue Doppler, one thing I often find is frequently done here is it's actually slightly rotated when we're in a 5-chamber view. We often get a little bit of sort of outflow tract involved there, which gives you these funny measurements. They're often it's less, and we know that the lateral annulus should be higher than the septal, but it's less because we're actually not truly measuring the angular displacement there. So unfortunately, you know, we do need to spend a little bit of time making certain that we optimize that 4-chamber view. Same thing. You know, we know the same thing with the facial size at the end. So Doppler is a bit of a pain that way. It is a Doppler, which means it's all angle dependent. Tissue Doppler still doesn't modify that. Strain, which you're going to talk about next, does, but if it's got Doppler in it, then we know it's all angle dependent. So we need to take that into account.
Exactly. So I will transition to the strain analysis now. So we use the 2D speckle tracking imaging to measure our myocardial deformation, and global longitudinal strain helps us diagnose and quantify the amount of dysfunction and reflects contractile dysfunction. So it's described as a unitless measure and recorded as a percentage of longitudinal deformation. And when we look at this number, what we need to remember is that more negative values essentially reflect more shortening, more contraction, more normal myocardium. Values nearing 0 demonstrate akinesis, and then positive values indicate dyskinesis. Now, depending on what vendors you're using, there's different cutoffs for the normal, but generally we think about -16 to -18% as being around the lower limit of normal. And this is an example from the ASC again, and then I'll show you our patient examples. But what we do for strain analysis is we take our different views in the apical window and put the tracker on, and each segment of the myocardium here is color coded. So our apex here is in green and pink, the green and pink lines here, base is in yellow and red, and the mid segments are in the blue. And as the myocardium is contracting, it's being graphed onto the plot on the left-hand side. And the more movement there is, you see, the more it's approaching that -20% area here. And the less movement, like near the base of the heart here, is close to 0 or the low negative values. So here we see that the apex is moving more, it's normal. Here we see a degree of dysfunction. The software then takes all of these measurements and plots them on a bullseye here, and we see the apical area is quite bright red, and this delineates a normal myocardium, and blue is more so the akinetic or dysfunctional myocardium. So in cardiac amyloid, when we do this bullseye, we typically see this apical sparing pattern. Our apex is moving great, but the rest of the heart is not as mobile. And we describe this as the cherry on top as well. Depending on what vendor you're using, your bullseye plot may look a bit differently. So the TomTech is panel A, GE is panel B, and Philips is panel C. But similar idea across all vendors.
1 minute.
Move your cursor up. You can click on the screen to get you going.
Okay.
Yeah, just leave it there. Check going. Thank you.
Because whenever there is chat.
You may have to open and close the chat and then it will go. Open and close the chat and it will go over.
I need to.
Good.
Open it.
You can close it.
And it will go.
It should.
So this is our patient example of the strain analysis we did. You can see we plotted the myocardium here. The segments are color coded again, similar to the example. And our GCS score is around -5 to -7%, which is abnormal. And this is just another view, and we can see the bullseye in the top right, which is that classic cardiac amyloid apical sparing phenomenon, cherry on top. So quite suspicious for cardiac amyloid. So how do we optimize our strain analysis? Number one, we can increase the gain. Higher gain gives us more speckles, better endocardial definition. Number two, we want to make sure our sector width and depth is consistent. We want the sector to be wide enough to include the full wall thickness and the apex and extend beyond the annulus. So when the LV is moving, we capture the entire cardiac cycle.
The heart rate has to be almost the same.
Yeah, and then no worries. ROI, region of interest. This we want to include 90% of our myocardium. So on the right-hand side, panel A is we've selected too narrow of a myocardium. Panel B is too much of the myocardium, and panel C is just right. And we can see how doing this incorrectly will manifest in different ways on our bullseye plot and can mislead us when trying to determine the diagnosis for this patient. And then, as our colleague mentioned, we also want to make sure that our ECG is gated appropriately at the time of end diastole and with the aortic valve opening and closing cycles as well. So when we do strain imaging, we should do strain imaging in patients that are referred for possible amyloid and the indication for the echo or with the red flags that we see on our initial images. Sometimes the GLS can be the first clue in determining the diagnosis when we have very subtle or no wall thickening. But it's also important to consider other pathologies that may be affecting the strain pattern, like a prior infarct or LV dysynchrony. And this is an example from ACE again, where a patient had some wall thickening here on the first external view, and they had a prior infarct in the apical anterior septal areas. So what happened to this patient essentially is that they got infiltration of amyloid in the non-scarred areas where their MI wasn't affected. And it did affect their bullseye plot here because they've scarred off that apical area where their MI occurred, but they still had amyloid. And doing the strain analysis was helpful in this case and guided biopsy of the appropriate cardiac tissue to make the diagnosis. And then just on the topic of strain analysis, I looked at some papers. This one was in JACC and looking at 2 and 3D myocardial strain in cardiac disease. And there's different factors that can impact our GLS. So afterload and preload. So the less afterload there is, the less strain we have, but as preload increases, the more strain can manifest. In the top right, we see that as the LV wall thickness and LV size changes, we really get a fluctuation of our GLS measurement based on those factors. If our myocardium is not contracting homogeneously, then that can also affect our strain. And then finally, if there's desynchrony, there's a conduction disease that can also impact our strain measurement. So important to keep these in mind when doing our analysis. And then here's a different strain patterns for patients with different cardiac disease. So panel A shows myocardial infarction, how our bullseye plot looks. We see that the area that's infarcted is not moving as well as the rest of the myocardium. Here in hypertrophic cardiomyopathy, we have a different strain pattern, and then our amyloid cherry on top pattern. And then I just pulled some papers looking at strain analysis. So this one was published in JACC as well for heart failure. It's a retrospective analysis of heart failure patients that had an EF of less than 40% initially, and then with medical therapy improved their ejection fraction by 10%. So they had an LVEF greater than 40% on analysis, and they analyzed these patients using GLS. And the primary outcome in this study was the time to the first occurrence of cardiovascular mortality or an hospitalization related to heart failure or needing emergency treatment. They included 289 patients with heart failure that then had improved ejection fraction, and the follow-up time was 53 months. And they took the absolute values of GLS. So remember how we said GLS is usually recorded as negative to positive values depending how sick the myocardium is. Well, they just took the absolute values and looked at that. Their mean absolute value was 12.7% in this study, and the average EF was 52%. And they found that the primary endpoint happened less frequency when the absolute GLS was above the median than below it. And then when they looked at GLS as a continuous variable, each 1% increase in the absolute GLS on the index echo was associated with a lower likelihood of the composite endpoint of mortality or heart failure hospitalization. And lower absolute GLS was associated with increased likelihood of deterioration in left ventricular ejection fraction. So GLS can be a helpful tool in predicting future heart failure events deteriorating cardiac function, and it shouldn't only be used in patients with a presumed diagnosis of cardiac amyloid. Another study that looked at the utility of echo and using atrial and ventricular strain in cardiac amyloid is on this slide. So here they took 136 patients with cardiac amyloid. 109 of these had the light chain variant, 23 had the transthyretin, and 4 had amyloid A type. They looked at the GLS in different areas. So they included here the left ventricle, right ventricle, the right atrium, and the left atrium. And they wanted to look at the primary outcome of all-cause mortality with a median 5-year follow-up. From the 136, the 127 actually had good enough images to proceed to strain analysis. And essentially their findings show that strain values from all 4 chambers that were measured were significantly associated with survival. And then the peak longitudinal left atrial strain and right ventricular strain remained independently associated with survival in the multivariable analysis. So kind of points towards using this software in different ways now to see how we can prognosticate these patients in the future. So when should we do the speckle tracking and the strain analysis? Number 1, if our study is highly suggestive of cardiac amyloid. Number 2, we have a high pretest clinical probability. And number 3, if there's this undifferentiated LV wall thickening. So the next part of my talk is going to focus on how do we report these findings and interpret the echo. the American Society of Echo recommends that if our findings are suspicious for CA, we should really make that obvious in our final impression and try not to bury this somewhere in the report where the clinicians might miss it. We should use wording like strongly suggestive of CA or infiltrative cardiomyopathy or not suggestive, and really help our other clinical colleagues know that this could be concerning and that they should do further testing for these patients. When looking at the parameters separately, so for LV wall thickness, we use a cutoff of 1.2 centimeters or RWT of greater than 0.42. So we often see that there's discordance between how thick the myocardium is and the voltages on our ECG. Like we saw in that patient, the myocardium was quite thick, but we had low voltage. This isn't always the case. You can't have a normal ECG with this presentation. So don't rule it out just from the ECG appearance. The echogenicity of the myocardium, as we also saw, we see that sparkling hyperrefractile texture, but this isn't only seen in cardiac amyloid. We can see it in patients with end-stage renal disease and other infiltrative cardiomyopathy. So look at it in conjunction with the other findings on our echo. Atrial size and function, the atria are going to be large. They might not have lower function. Another non-specific finding, but again, taken together with the other findings can be helpful, and it can also give us insight into the risk for stroke or arterial embolism. We also saw our patient had some interatrial septum thickening and thickening of the valves as well. So another non-specific but suggestive finding. Pericardial effusion as well should raise some red flags about cardiac amyloid. And then we spoke at length about our diastolic dysfunction, grade 2 or worse diastolic dysfunction. Your E to A ratio is high, greater than 1.5 with a reduced deceleration time. This can be very helpful, not only in quantifying the amount of diastolic dysfunction, but also prognosticating our patients. And the lower the A wave, the more helpful it is in determining the risk of stroke in these patients. And patients with an A wave that's less than 30 centimeters per second often have a higher risk of thromboembolism when they're in sinus rhythm and cardiac amyloid. And then finally, our pulmonary vein atrial reversal may also be suggestive of elevated LVEDP and atrial function. PA pressures greater than 35 or right atrial pressures greater than 10 are also helpful in estimating the volume status for these patients and optimizing diuretics. And then when looking at our annular tissue, mitral annular tissue Dopplers, I think the mnemonic 555 is useful. The tissue Dopplers are often less than 5 centimeters per second in these sorts of cases. Our longitudinal LV strain analysis, which we talked quite a bit about, is helpful as well. And the bullseye map is actually the most specific sign to rule in a diagnosis of CA. So if you see that apical sparing cherry on top appearance, this is almost a slam dunk to making this diagnosis. When reviewing the CCS guidelines, they recommend that we do serial imaging with echo or cardiac MRI, in addition to measuring natriuretic peptides to monitor the disease progression and response to therapy. They don't really comment on an optimal monitoring frequency. They recommend a range between 6 and 48 months, but this can fluctuate based on how well the patient is doing or if they're having any clinical deterioration. Obviously, you would think about imaging them sooner. And they recommend using imaging in addition to serum biomarkers together. Nuclear scintigraphy with the bone-seeking tracers is not commonly recommended to monitor disease progression or the response to therapy. So when looking at serial assessments using echo, is this actually useful? And there's several studies that have looked at echo in assessing disease progression and response to therapy and show that echo is actually quite beneficial. So in one circumstance. It can demonstrate changes in cardiac disease in response to treatment in AL and ATTR-CA. It can help determine if patients with CA need to be anticoagulated for stroke prophylaxis, can help diagnose progressive involvement in the heart after someone gets a liver transplant for ATTR amyloid, can help assess LVEF with AL amyloid patients who are being considered for a stem cell transplant. And the newer data is actually suggesting that GLS can be a marker of disease progression and how well the patients are responding to therapy. So to summarize, I think I want everyone to have these red flags in mind when they're scanning these patients. So if you see pleural or pericardial effusions, biventricular thickness, thickened valves, thickened interatrial septum, having a low stroke volume or low flow, low gradient aortic stenosis, those are some important signs. When we're doing our measurements on Doppler, is our E to A ratio greater than 1.5? Are we having blunting of our S wave with accentuation of the D wave in the pulmonary vein Dopplers? The 555 rule for tissue Dopplers, having low velocities there. And then finally using GLS strain analysis to further delineate our diagnosis, and seeing that classic apical sparing pattern can be very helpful. So we went over the pathophysiology of amyloid, how these patients present, common red flags, and how to use appropriate echo techniques when assessing structures for cardiac amyloid. These are my references.
Oh, yeah. I have a question. I'm sorry, I came in late. You may have said it earlier. Is that not so smart? For like patients with amyloidosis, kind of issue.
What's causing patients to have amyloid?
No, pericardial effusion.
Pericardial effusion. Is it because of the inflammation?
I'm not actually sure of the pathophys behind the pericardial effusion, to be honest.
Yeah, I don't think there's a clear explanation. You know, it's multifactorial. As you know, like in conditions like significant pulmonary hypertension, elevated pressures, get a pericardial effusion there, it's a worse prognosis. So there's got to be changes in pressure within the ventricles that can drive it. There's probably also changes in the normal flow of fluid within the pericardial space, because you get this deposition of stuff, you get inflammation, and then there's the sort of broader systemic effects that you get with whatever the underlying etiology of the amyloid is as well. So again, it's not pathognomonic, it's just part of what we see there. They're usually small though, as you know, they're not usually very large pericardial effusions. Never, if it's associated with tamponade or any other things like that, then we say we need to look for an alternate etiology for it. This is not part of the amyloid process, there's something else going on. But as to the specific answer to your question, I actually don't know. It's a bit like, why do we get in colosine and PE? We've got a few theories, but we don't really know one of them. So, yeah. I mean, the pleural effusions are all clear, aren't they? Because you've got filling pressure, so now you've just got back pressure and so on. But pericardial effusions are probably a bit more multifactorial.
Yes.
Why there's a about sparing?
I think, is it because the proteins don't really favor that area on the...
No, it's probably not. I think, you know, generally we know this is diffuse disease from MRI. If we look at intracellular volume, which is another marker of tissue deposition of amyloid fibrils, that it does occur throughout the myocardium there. It's probably just due to do actually the tethering the different segments of what we're actually measuring. So this sort of concept that strain is sort of completely load independent is wrong, and that it truly doesn't impacted by translational effects is also not quite true. So, because remember what we've done is we've taken a 3D structure that rotates and twists, and we've given velocity vectors to try and cover that. So it just so happens, as you know, normally what happens with strain, which is why we measure on tissue Doppler, is that the base moves, right? And the apex stays relatively fixed. And in amyloid, because what we think happening is you now get this long deposition throughout the entire myocardium. The sum total of that effects is that there's actually less motion at the annulus relative to the apex. So that's why it looks as though there's a relative change there. Now, the problem is we've tried to do regional strain to look at the base and midwall, but as you know, it's really noisy. So it just hasn't been, the fidelity is not good enough now to actually be able to say we can do local regional strain assessment and actually determine what's going on in a particular location to see if there's, for instance, differential protein deposition that occurs. So we just don't know that. And we've done that lots of times. Like we've tried to do it in coronary artery disease, where we, looked at people with chronic total occlusions and tried to look in the territory of interest, like the right coronary artery, and we've specifically looked at those segments, and it's a random number generator. We don't really know why, other than the technique does have noise. Maybe with newer AI algorithms, where you can incorporate more spectral tracking, get rid of more noise and actually identify better signal. But as you know, it hasn't panned out yet. It's been a bit of a disappointment for strain, because we're hoping it will give us much better regional. So, for instance, if you had someone who's got coronary disease, whatever, then you can say, aha, it's not the global defect that's down, it's actually in this territory. This is sort of a non-invasive marker of what's going on, but it hasn't panned out. You'll read a few research studies that have looked at it, but clinically it's not evolved. So that's my best explanation of why
Doesn't
you get
mean
that.
that there's no deposition.
No.
All information. It's just a tool that.
No, correct. No, we think that, and that's why, like, as you get more advanced in the disease, you do get the atrial thickening, the valvular dysfunction. It is a very broad deposition of these amyloid fibrils. And that's partly why it looks similar to people who have end-stage renal disease. You get two things there. You also get amyloid deposition. Depends on what membrane you use during dialysis. And that's why you often the best way to tell if this is end-stage renal disease or true transthyretin is look at the referrer. If it's front wall, the jordan wall, yeah, Jeff, then you know this is probably renal dysfunction. Now, that doesn't mean that they're not actually having protein deposition. They probably are. There are some studies with some of the newer filtration units that they use in dialysis that you can actually prevent this from happening. But that's different from the true ATTR wild type amyloid type amyloidosis, for which now we have specific therapies for. So that's why that is important. But that's why the pattern sometimes looks, guys, what it's like. They got LVAs, they got a little bit of pleural pericardial effusion, they've got a little bit thick, they got big atria, looks the same. So it's the same process, but how you get there is different. Right?
Okay, another question. How is hemochromatosis different from amyloid?
Oh, so hemochromatosis is quite different. So hemochromatosis, I don't know, Marie, you probably, I'm happy to talk about it. But if you want to. Okay, so hemochromatosis is a commonly inherited condition which is associated with usually a couple of gene defects that modify iron loading. And so you get iron deposition throughout organs, and it's quite variable. So typically it affects the liver, pancreas, you get diabetes, it can affect the joints, you get particular changes in the joints, but it can also have direct cardiac deposition. But here you get a direct iron toxic mediated reactive oxygen species effect, which is directly toxic to the myocardium. And so it came around that this iron loading is generally unusual with hemochromatosis. We're much more likely to see the toxic effects in iron loading conditions, which classically is thalassemia. So people have thalassemia and they require frequent transfusions. And as you know,